my name's Alicia. Today I'm going to be taking you through the pre-hospital management of shoulder dystocia. Shoulder dystocia is a birthing emergency. It occurs because the fetal bisacromial diameter, so the distance between the fetal shoulders, exceeds that of the maternal anterior posterior pelvic inlet diameter, so the distance between the top and the bottom of the maternal pelvis. The shoulders are unable to deliver spontaneously past the maternal pubic symphysis or the sacral promontory. There are three broad goals associated with the manoeuvres that we use to relieve shoulder dystocia. The first is to reduce the fetal bisacromial diameter. The second is to increase the relative maternal pelvic inlet diameter. And the third is to maneuver the fetus into the oblique plane to relieve a degree of the disproportion. Pre-hospital management of shoulder dystocia is guided by the Green Top Guidelines. These are endorsed by both the Royal College and the Royal Australian and New Zealand College of Obstetricians and Gynecologists, and they're what I'm going to be referring to largely throughout our discussion today. This presentation is going to focus predominantly on the manoeuvres that we use to resolve a shoulder dystocia, but it is important to consider the things that we would include in our assessment and our preparation of the scene. So these include our dynamic scene safety assessment, our primary and secondary surveys, a detailed obstetrics history, as well as the equipment required to safely deliver the fetus and then potentially resuscitate both the neonate and the mother. So for us, that includes our PPE, a fluid-resistant gown, gloves and eyewear, our maternity kit, including a blanket to warm and dry the child after birth, clamps, suction, airway adjuncts, and a neonatal-sized bag valve mask, and then equipment for the mother as well. So we're going to need a fully stocked drug kit, a defibrillator with monitoring capability, and adult resuscitation equipment. There are a number of features that can help us recognize a shoulder dystocia. Difficulty delivering the head and the face, failure of the head to restitute once it's been delivered, and then tight retraction of the head against the perineum, also known as the turtle sign, are all indicative of shoulder dystocia. This diagnosis is then confirmed when our normal gentle axial traction fails to deliver the fetal shoulders. At this point, we need to recognize a time-critical emergency. We need to activate the most senior pre-hospital resources that we have. We also need to activate another fully equipped transport crew and consider contacting a senior obstetrician or activating a pre-hospital obstetrics team if that's available. We need to inform the mother of the shoulder dystocia and then keep her informed throughout our following manoeuvres. We also need to start a timer for 5 minutes because we know this is the time frame we have to deliver the infant before their outcomes significantly worsen. The Royal College of Obstetricians and Gynecologists recommend their shoulder dystocia algorithm as it's been demonstrated to improve clinical management and neonatal outcomes. The first manoeuvre of this algorithm is McRoberts. It's a first-line manoeuvre because it's effective and it's non-invasive. There are no contraindications, however the mother will require assistance, which can be limited in the pre-hospital environment. What we need to do is discourage her from pushing, assist her to move her buttocks towards the edge of the bed, and then to flex her thighs up against her chest. And then this position needs to be maintained. What this achieves is that it shifts the angle of the pubis symphysis from being quite diagonal to more horizontal. This increases the relative maternal anterior posterior pelvic diameter, which we recall is disproportionate to the fetal's bisacromial diameter. We hold this position for 30 seconds. According to Sar Phillips and Van Hoover in 2020, McRoberts alone resolves up to 42% of shoulder dystocia. Rubens 1 is our next manoeuvre. This is continuous suprapubic pressure. There are no contraindications to Rubin 1, but there is the risk of worsening the shoulder impaction or causing a uterine rupture by applying pressure inappropriately to the fundus. What we do need is a hand placed slightly superior to the pubis symphysis, and then firm downward lateral pressure behind the fetal anterior shoulder. Standard gentle axial traction should be applied as standard. The goal is to reduce the fetal bisacromial diameter by displacing the anterior shoulder forward towards the fetal chest, and then hopefully physically shift the fetus into the oblique plane, which should displace that anterior shoulder and allow it to pass below the pubis symphysis. We hold this position for 30 seconds. McRoberts plus the Rubin 1 resolves 77% of shoulder dystocia. in a 2018 review by Micheletti et al. If after 30 seconds our Rubens 1 hasn't relieved the shoulder dystocia, we add a firm rocking motion to the Rubens 1, which is not dissimilar to a CPR motion. We will now discuss the internal manoeuvres as per the Royal College of Obstetricians and Gynecologists algorithm. However, it should be appreciated that these may not be within the scope of all paramedics. It's also important to appreciate that the fetal and maternal outcomes worsen significantly as the number and invasiveness of our manoeuvres increases. In hospital, an episiotomy would be considered at this point. However, this is largely beyond the scope of paramedics. We do need to keep the mother informed and gain consent for the invasive procedures to follow. Rubens 2 is the first of the internal manoeuvres. Due to the dire maternal and fetal consequences associated with unresolved shoulder dystocia, internal manoeuvres are only contraindicated if they fall outside the paramedic scope of practice or if the mother does not provide consent. Communication with the mother is essential to ease distress and improve compliance with these manoeuvres. Rubens 2 is the internal equivalent of Rubens 1 and can be combined with Rubens 1 with the help of an assistant. The goal is to reduce the fetal bisacromial diameter by displacing the anterior shoulder towards the fetal chest, hopefully displacing that fetus into the oblique plane and facilitating displacement of that anterior shoulder below the pubic symphysis. 2 fingers are inserted into the vagina behind the anterior shoulder in the posterior placement. The head is supported. We then want to apply direct pressure behind the fetal anterior shoulder, attempting to dislodge it. The wood screw and reverse wood screw manoeuvre follow Rubin 2 if it's been unsuccessful at resolving the shoulder dystocia. The goal is the physical displacement of the anterior shoulder below the pubic arch. During this, Rubin 1 and Rubin 2 are maintained. From here, 2 fingers are inserted into the vagina to rest on the anterior aspect of the posterior shoulder. A rotational force is then applied for 30 seconds in an attempt to shift the anterior shoulder below the pubic arch. If this is unsuccessful, our fingers are removed from the posterior shoulder. Our anterior fingers slide down to rest behind the posterior shoulder, and then we are going to reverse the direction of our pressure. So again, attempting to manipulate the fetal shoulders. We'll apply this for another 30 seconds. Our final internal manoeuvre is to deliver the posterior arm. So the goal of this is to reduce the fetal bisacromial diameter, which will hopefully displace that impacted anterior shoulder. So to do this, a hand is inserted into the vagina and the fetal posterior wrist is identified. Once it's found, it's grasped and it is swept over the fetal anterior chest and delivered. We then utilize our standard gentle axial traction, which should facilitate delivery of the rest of the neonate. Now, because we have used significant maneuvers to deliver this neonate, it is unlikely that it will not require resuscitation. So we are going to move him directly to an area where he can be warmed, dried, and have a rapid assessment of his APGAR performed, with resuscitation implemented as required. As per the World Health Organization guidelines, if the neonate required resuscitation, we'd undertake immediate cord clamping to facilitate this, in contrast to the standard delayed cord clamping that WHO currently recommend 1 to 3 minutes post-birth. The placenta can take time to deliver, and we would not delay on scene to accommodate that. We would instigate rapid transport with pre-notification and facilitate delivery of the placenta en route, whilst also considering active management of the 3rd stage of labour through the use of oxytocin as per the WHO guidelines. Gaskin's, or all-force manoeuvre, is the final manoeuvre that's endorsed by the Royal College of Obstetricians and Gynecologists. It's often left until last because of the significant time and maternal effort that's required to achieve the position, and maternal exhaustion is usually the limiting factor here. It's also contraindicated during transport because of the significant danger associated with unrestrained manipulation of the mother's position. The combination of the maternal movement, gravity, and the increase in pelvic diameter has been demonstrated to relieve shoulder dystocia in 83% of cases. Now, given that this maneuver often exhausts our pre-hospital options, this is a really reassuring statistic. Recognised but not yet endorsed is the posterior axillary sling traction maneuver, which involves utilising a sling to apply traction to the posterior axillary in attempts to deliver the posterior shoulder. It's been recognised by the Royal Australian and New Zealand College of Obstetricians and Gynaecologists as an option for when our traditional manoeuvres fail. A clitotomy, a symphysiotomy, or the Zanzanelli manoeuvre can be attempted in hospital, but these all carry significant risk and are well outside the pre-hospital scope. In conclusion, shoulder dystocia is a challenging and time-critical obstetric emergency. The manoeuvres are effective, however, they're evidence-based, and they resolve shoulder dystocia in the majority of cases. It is important, though, that we maintain a keen appreciation for the definitive care required by a critically unwell child and mother.